You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 25th, 2019. This week, I'm talking about atrial fibrillation after TAVR, opioids after cardiac devices, hypertension in Black adults, and postoperative atrial fibrillation. First topic today is TAVR and AFib. An increasing number of patients have their aortic stenosis treated with trans-aortic valve replacement or TAVR. A study published recently in JACC Intervention suggests there is more to learn about TAVR than just how to choose and implant this valve. Patients who have TAVR are usually older and often have other cardiac issues, say, for instance, atrial fibrillation. American authors led by a group from the University of Iowa looked at more than 72,000 patients older than age 65 who had non-apical TAVR from 2014 to 2016. They used a Medicare claims database to assess the impact of new onset or pre-existing AFib on the long-term outcomes for TAVR. The comparator arm in this study were patients who had TAVR who did not have atrial fibrillation. Now, about 40% of patients had pre-existing AFib and 7% had post-TAVR new-onset AFib. Patients with AFib before the procedure had more comorbid conditions, which you'd expect. Yet during follow-up, mortality was higher in the group with new-onset AFib compared with pre-existing AFib or no AFib. Mortality was 30% with new atrial fibrillation, 23% with pre-existing, and 13% with no AFib, and the p-value was highly significant. After adjustment for lots of different patient characteristics and TAVR volume, new-onset AFib remained associated with a greater than twofold higher mortality compared with no AFib. The adjusted hazard ratio for pre-existing AFib was lower at 1.35. Now, the authors did something called a competing risk analysis, and this showed that new AFib after TAVR significantly associated also with higher rates of bleeding, stroke, and heart failure compared with pre-existing AFib. So the main finding that new AFib seemed worse than pre-existing AFib surprised me a bit. This is a retrospective, non-randomized observational data using claims, so we have to be cautious about it, but still, it's worth noting the seriousness of AFib in these patients. And AFib is tricky. I often rail against scaring patients who have AFib, say younger people or people with reversible causes of AFib. In fact, it defies good medical practice to scare these patients, as doing so sets the stage for overtreatment. However, AFib in older patients, and the mean age of patients in this study was 80 plus, and they also had comorbid conditions, is different. This sort of AFib in these sicker patients warrants action, regardless of whether it is due to the procedure or the underlying heart disease. Notable is a recent registry study that the authors cited showing that less than 30% of patients with post-TAVR new-onset AFib were discharged on anticoagulation. Less than 30%. That seems low. Though, to be fair, we don't have RCT-level data to guide our anticoagulation choices. Rate control of AFib also can be especially important in vulnerable elders with diastolic and systolic heart failure. Now, excuse my extreme bias here as an electrophysiologist, but I would propose that TAVR centers partner closely with their EP colleagues, because I think it's likely that we can help treat these sicker than usual AFib patients. The next topic today is opioids after cardiac device implants. The journal Heart Rhythm recently published a useful descriptive study from Mayo Clinic researchers on opioid prescribing practices after cardiac devices at 3 Mayo centers in the United States. This was a very large survey, as it included 16,500 patients implanted from 2010 to March of 2018. The top-line finding was that 1 in 5 patients with a cardiac device was discharged home with a prescription for opioid pain relievers. Now, while 1 in 5 patients receiving an opioid seems low, 4 out of 5 did not get one, 3 other findings in this study should open our eyes. First, nearly 1 in 10 patients ended up getting a refill for their pain meds. Second, among patients who received an opioid, 39% received more than 200 oral morphine equivalents. Third, the authors noted large amounts of regional variation in opioid prescribing in the 3 regions of the U.S. in which the Mayo Centers were at. Journalist Patrice Wendling has an excellent news piece covering the study, and I was happy to offer her some comments. First, this is an important study. It shows that the use of opioids after devices is still substantial. I am struck by the large proportion of patients who received more than 200 oral morphine equivalents. That's approximately 30 to 40 standard hydrocodone tablets. That's a lot for any kind of cardiac device. Plus, nearly 1 in 10 patients who received opioids had a refill. That too seems like an outlier. Also notable in the study was the regional variation, and regional variation in something as routine as post-cardiac device pain management is worth noting. My practice for post-op cardiac device pain has significantly changed. Before the opioid epidemic was recognized, I would routinely prescribe low-dose, short-duration opioids after most cardiac devices. I felt like it was the right and compassionate thing to do. I thought short-duration and low-dose opioids were safe and the benefits outweighed the risk. I was wrong. Beginning around 2016, I began prescribing opioids far less often, and now I rarely prescribe them after an EP procedure. Now, this change occurred in large part because I and my colleagues underappreciated the issue of opioid dependence. Even small doses of these drugs over the short run can cause dependence issues. I have learned to greatly fear these drugs. There's a really important New York Times opinion piece on post-op opioids written by a patient. The title of this piece really changed my view. It was called "After Surgery in Germany, I Wanted Vicodin, Not Herbal Tea." And I'll link to this in the show notes, and I would really encourage you all to read it. The German doctors in that piece had it right. We should be telling our patients that pain is normal after surgery, and that it will improve quickly, and pain is a sign to let your body heal. I now tell my patients that there is some pain afterwards, but it will be neither severe nor long-lasting after a cardiac device. And finally, my friends, how the medical profession was duped by industry, and how the policy of pain as a 5th vital sign harmed patients should be a history lesson that's taught in all medical and nursing schools. The third topic today is hypertension in U.S. Black patients. An epidemiologic study published in JAMA Cardiology by numerous American authors explores the population attributable risk for cardiovascular disease associated with high blood pressure in Black adults. Now, in epidemiology, the PAR, or population attributable risk, is the number or proportion of cases that would not occur in the population if that factor were eliminated. For example, how many lives would be saved if people never smoked, or in this case, were not exposed to hypertension? The PAR, population attributable risk, depends on both the prevalence of the risk factor and the strength of its association with the disease. And here is what I mean. The attributable risk of a factor is the difference in outcomes between an exposed group and an unexposed group. And this is mostly calculated in cohort studies where individuals are assembled on exposure status, say smoking or asymptomatic carotid disease, or in this particular case, hypertension. And these individuals are followed over time for major adverse cardiac events. Now, the attributable risk is not the same as the population attributable risk, as the PAR depends on the total share of the population that is exposed. Consider that a bad thing like smoking will not have much of a population attributable risk if smoking in that population is rare. So to find the PAR, you have to multiply the attributable risk, which is the risk difference, by the amount of the risk factor in the population. And indeed, this particular study used data from 2 prospective cohort studies called the Jackson Heart Study and the REGARD Study. Well, first of all, of the 12,500 participants, hypertension was common. It was seen in 53% of black participants. So right off the bat, you can predict that if the risk difference in outcomes, those with or those without hypertension, is big, the PAR is going to be high. And yes, the first data point is as expected. Exposure to hypertension doubled the risk of major adverse cardiac events. From Table 2 of the paper, for instance, the incidence of stroke in patients with normal blood pressure was only 1.5%, but the incidence of stroke in patients with hypertension was 4.3%. The PAR, the population attributable risk associated with hypertension, was 33% for any cardiovascular disease, 43% for coronary disease, 21% for heart failure, and nearly 40% for stroke. The PAR was higher among those younger than 60 versus those older than 60. Now, before I tell you the massive significance of this finding, it's useful to note the PAR of other risk factors. For instance, diabetes is only 13%, for hypercholesterolemia 10%, obesity 5%, and smoking 12%. So the population attributable risk for hypertension is much higher than other typical risk factors. Now, the relevance of these findings relates to what I said about PAR in the beginning of this session. The PAR is the number of cases that would not occur in a population if the factor were eliminated. Here, nearly a third of major cardiac events could be eliminated simply by not letting people be exposed to hypertension. These two cohort studies, which are likely representative of the general population, found that half of black adults had hypertension. So if you apply this to the total population of black adults in the U.S., efforts to prevent and treat hypertension would be hugely beneficial. Now, I have to say, while a lot of what is considered cool and sexy in cardiology are flat-of-the-curve interventions, things like AF ablation, Impella, PCI for stable coronary disease, treating and preventing high blood pressure in black adults is surely a high-value intervention that sits on the steep part of the value versus cost curve. The authors rightly point out that just getting meds to people isn't the whole solution. Rather, one must think about primordial prevention, that is, not letting high blood pressure start in the first place. Of course, primordial prevention, which is education, walkable and rideable neighborhoods, available healthy food, these are not clinical interventions, these are societal interventions that must occur politically. Thus, this really important paper informs both clinical practice and public policy. Next topic today is postoperative atrial fibrillation, specifically post-cardiac surgery AFib. Now, one of the most common questions in cardiology today is whether a patient with post-cardiac surgery should receive oral anticoagulation. On the one hand, you could say these patients are at high risk of bleeding. They just had surgery. And the atrial fibrillation is often gone after 6 weeks of healing, so don't treat it. But on the other hand, postoperative atrial fibrillation may be a marker for stroke risk, and it is worth treating. Now, you know a couple basic facts about post-cardiac surgery AFib. Number one, it's common. Almost half of patients who have valve surgery will have AFib afterwards. It's not such a big question when patients have AFib with mechanical valves because these patients will have to get vitamin K antagonist, for example, warfarin. But with bioprosthetic valves, it is a big question. Now, another basic fact about post-cardiac surgery AFib is that it is not nothing. Having post-op AFib increases one's risk for having AFib in the future. So, investigators from Denmark, publishing in JAMA Cardiology, they used a post-cardiac surgery registry, and they compared that with national health data in Denmark to compare the risks of post-op AFib after valve surgery on the mitral or aortic valve with patients who have non-surgical AFib. Of course, this is a non-randomized comparison of about 675 patients with post-op AFib versus a matched cohort of 2,000 patients with non-valvular AFib. Now, the time frame of this study is a strength. They looked at a 15-year period. Here are some of the findings. Oral anticoagulation therapy was initiated within 30 days post-discharge in 420 patients with post-op AFib. That's about 63%. And oral anticoagulation was used in 51% of patients with non-valvular AFib. Unadjusted, the rates of thromboembolism were 22% per 1,000 patient years for post-op AFib and 17.7% for non-valvular AFib. So rates of thromboembolism were higher in post-op AFib. In adjusted analyses, the long-term risk of thromboembolism was similar in patients with post-op AFib and non-valvular AFib. The hazard ratio here was 1.22 and the confidence intervals were spanning 1.0. So post-operative AFib did not look to be less risky than regular atrial fib. But the key finding from this study was that oral anticoagulation therapy versus no anticoagulation during follow-up was associated with a 55% lower risk of thromboembolic events in patients with post-op AFib, that versus a 37% lower risk in non-valvular AFib, and both were significant as the upper bound of the confidence interval here was less than 1.0. The consistently reasonable and very nice Dr. Jonathan Piccini has a great editorial. He writes that the best conclusion of this observational study is that oral anticoagulation for post-op AFib after left-sided valve surgery may be beneficial. Emphasis on maybe. That is, of course, because this is a non-randomized study and you don't know whether patients on oral anticoagulation did better because of the drug or whether they received the drug because they were healthier to begin with. Remember, statistical adjustment can only be done for those characteristics seen on a spreadsheet. And obviously, not all of important data is able to be captured on a spreadsheet. Piccini does tell us that an RCT called PACES is studying whether adding oral anticoagulation to antiplatelets is superior to antiplatelet drugs alone in these patients. This is important because there is a strong need for data to inform our choices in post-op AFib. Now, first, an announcement before I close. Next week, I travel to Edinburgh, Scotland. On Thursday, I'm honored to give the Ray Gilchrist Lecture at the Royal College of Physicians in Edinburgh. The title of my talk is Words That Maim, Words That Heal. I will do This Week in Cardiology, but will not have my normal recording devices, and I will record it earlier in the week than normal. So as always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please tell a friend, take the time to subscribe, and give us a review as it helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.